It's my great pleasure to invite our last speaker of the morning, a very close personal friend. It's Professor Chris Packard from the University of Glasgow. He's Professor of Vascular Biochemistry and R&D Director at NHS Greater Glasgow. More importantly, from when you listen to Chris, is not only is he absolutely a brilliant biochemist and a scientist, but he actually has a very practical head. So he knows as much about epidemiology as I do, which is, you know, I mean, it's quite a feat. So it just shows you that if you're trying to challenge, if you're trying to answer important questions, you've actually got to have a 35,000-foot view, the focus, and also really understand why you're doing it. And I'm looking forward to your talk. Thank you, Chris.
Thanks, Josh. And thanks to St. George's for inviting me down from the soon-to-be independent Scotland, along with Catalonia, obviously. My task this morning is to examine the story of CETP and its potential as a target for CHD prevention. And we've actually had a lot of elegant biology and lipoproteinology with regard to HDL, and that is a great platform on which to present something that is a climb out towards, as Scott said, a practical and clinical view of what might be going on. Beware of dogma, and beware of dogma delivered by bald people with grey hair. And the more bald they are and the grey they are, the more you should be wary. I speak to you young clinician scientists in the audience. Here is a slide that I have presented for many years, and you've seen some of it before, which says that on a statin, there is an event rate associated with HDL that's as inverse and as powerful as those on placebo. And that was our pravastatin pooling project that included CARE, Lipid, WASCOPS. And here's Phil Barter's analysis of the TNT trial, where even the individuals who were on the highest dose of statin showed, statistically at least, an association, an inverse association with HDL. And there the story stops. However, there are rumbles in the jungle where we see in the PROSPER trial that we did, HDL is a very powerful risk factor until you start to put in the lipid factors and the inflammatory factors. If you put in white cell count, LPPLA2 as a marker of inflammation, and CRP, instead of having a hazard ratio of 0.75 for HDL, the hazard ratio is now 0.99, and it's completely not significant. So you have to ask yourself, when you see the data, have they fully corrected for all the things that you've heard about today, particularly inflammation, oxidation potential, and other things? And if they did that, would those curves begin to flatten? In PROSPER and in JUPITER, if you were on a statin, the association with HDL was flat. And whereas the association with placebo was, on placebo was still strong. So also, how do statins, when you achieve low LDL levels, modify the association of HDL with risk? And the big question that's facing us now with PCSK9 inhibitors, where you can get LDL down to 0.5 of a millimole, is does anything need to happen to HDL when LDL is so low? That's an aside. I just wanted to say that as a kind of point. We are in the process of trying to find new targets for LDL lowering and for HDL raising. I'm going to touch on CETP inhibition, but there are lots of other things that are coming. We're moving from a statin era to a beyond statin era, and it'll be very interesting to see what will happen. The bar is very high with regard to what you have to do once you're on high-dose statin in terms of reducing risk further. So one way we can do that is to actually look at CETP. I'm going to look at its role in HDL and LDL physiology, a bit of epidemiology, and then look at the CETP inhibitors themselves, those that have been developed to date. So here's CETP. Cholesterol ester transfer protein is a promiscuous shuttle protein. It doesn't care who it cuddles at night, it will cuddle LDL or VLDL and pick up a triglyceride or a cholesterol ester molecule, and it'll drop that in another particle. So it actually doesn't matter about the directionality or whether it's a cholesterol ester or triglyceride. What matters is the dynamics of the system. And the dynamics of the system are such is that triglyceride, which is in abundance in VLDL, is transferred into HDL, and cholesterol ester, which is swept from peripheral tissues, including the aorta or the artery wall, but that's a small amount of the excess cholesterol you have in your tissues, comes into HDL, it's captured there, and it's transferred into VLDL. And you can see, as all of us have done, when you eat fat, the cholesterol ester will be transferred from HDL into chylomicrons or VLDL. The hypothesis is that if you block CETP's action, you stop the cholesterol ester that is being transported from HDL, from artery walls into HDL, transferring out back to VLDL and LDL that would end up back in the artery wall in a kind of futile cycle. And you promote reverse cholesterol transport through liver receptors that will pick up that cholesterol, particularly from HDL. That's a beautifully simple hypothesis. CETP inhibition, therefore, should lower LDL cholesterol because it's blocking the transfer in. It should increase HDL cholesterol, and if the sore is good, we should actually have more reverse cholesterol transport, and it's exported from the body in the feces. And that's what has been explored at great cost over the last few years. It's always good to cast around for lessons of nature. Here's one. The rat, or rodents in particular, have no CETP. You can feed them what you like. They will not get atherosclerosis. You have to manipulate them in other ways. HDL is the major carrier. And if you start to give them human-like proteins, including CETP, they will start to get atherosclerosis. So rodents, yeah, maybe that's a lesson of nature we can live with. CETP deficiency is present in humans, particularly in Japan and Korean people of Japanese and Korean descent, where it is the gene is blocked, and they end up with very high HDL cholesterol levels, 3-4 millimoles per litre, low LDL levels. But unlike FH, that links the LDL receptor to atherosclerosis, having no CETP is not intimately linked to having no coronary heart disease. The association is very unclear, and this has been reviewed a few times. Phil Bartlett was one who reviewed it early on, but even now, the epidemiology of that genetic disorder is not clear. So a question mark appears over blocking CETP. This is just to say that CETP activity alters all the particles that Lena and Arnold have talked about, and Julian early on. And at the moment, because we don't know which particle is linked to protection from coronary heart disease, if protection is due to HDL variation, therefore we don't know what CETP does to the family of HDL particles that is going to be beneficial. So we're 2 steps away from clarity in that regard. One thing we do know is that CETP is linked to a very common dyslipidemia that's seen in type 2 diabetes and in the metabolic syndrome, obesity. And that is raised VLDL, increased chylomicron remnants, small dense LDL, and low HDL. And our group in Glasgow, Muriel and I and Jim over many years have shown that CETP is central to the development of an atherogenic lipoprotein phenotype because, of course, when it's hyperactive, it moves cholesterol from HDL into these particles and induces changes. So ALP, which we believe is a risk paradigm or a risk syndrome, is linked to CETP. So CETP and HDL is one part of the story, but CETP and VLDL remnants and LDL is another part of the story. There's a decent hypothesis, therefore, in the CETP story and its link to coronary prevention. What can we learn from epidemiology? Well, way back, we and many others looked at variations in the CETP gene. And there is a variation in the, that's linked to a variation in the promoter region that gives you changes in activity and mass of CETP. CC is the one of the wild type, AA is the other. They're actually about equally common, you can see that. 3 milligrams per litre, 3.4. Activity goes down about 40% if you have another variation in that gene. And that variation in the gene is linked to higher HDL cholesterol levels, higher HDL2 mass, but no change in HDL3 in terms of its epidemiology. So here is a natural variation in the population that give rise to higher HDL levels and higher HDL2 mass. So how does that link to coronary disease? Well, I love these slides where p-values are 10 to the minus 380. I wish I could get that on a regular basis. But that's how these GWASs work. CETP was picked out as one of the markers of lipid control and one of the predictors. CETP gene was one of the predictors of coronary variation in coronary disease, and it was highly significant along with hepatic lipase, the LDL receptor, and ApoE. So it's one of a small number of extremely potent genetic risk factors for coronary disease. And the Cambridge group showed that, Alec Thompson and others showed that if you inherit the A allele that I talked about, you have a lower CETP mass, you have a lower CETP activity, you have a higher HDL and A1, and you have a lower odds ratio for developing coronary disease. So the story is stacking up. Reduce your CETP by about 30–40%, and you'll get reduced risk of coronary disease per variant allele that you get. But can you have too little of a bad thing? Possibly. Let's turn again to the CETP deficient human mutants. When you get lack of CETP, you get extreme changes in LDL and HDL. Here's the normal individuals in these families from Japan. Here are the people in green who have no CETP. Two things. The LDL changes from a size of about 220 angstroms across to about 150, 170 angstroms across. And you just don't see that anywhere else. So here is a very small, dense LDL. And you can see that on anacetrapib. You can see that on very severe CETP inhibition. HDL goes from about 100 nanometers across up to much bigger size, 130 nanometers across, something like that. So HDL has got much, much bigger and changed in its properties, and LDL has got much, much smaller if you have almost no CETP activity because of this genetic variant. So how does that relate to disease? And I've already said that it's not clear at all how that relates to disease in the naturally occurring variations. Just to make matters more complex, in the Framingham study, which is a famous epidemiology study, they looked at CETP activity, and here are the hazard ratios, 0.75, great, but that was the hazard ratio if you had a higher than mean CETP, not a lower than mean CETP. So it's going the wrong way in the epidemiology when you measure activity. Here's another wrinkle. In individuals in the Prove It study, some of them were on pravastatin, some of them were on rosuvastatin. If you look at their LDL cholesterol, whether it's below the median or above the median, which is about 80 milligrams per deciliter, if you had a high-ish LDL on these drugs, CETP activity, whether it was high or low, had no effect on outcome. But if you had a low LDL, you needed a high CETP, this is higher than the median, to give you a low risk. Again, CETP that was high was associated with a lower risk when you had lower LDL, and that was a significant interaction. So something strange is going on, something subtle we don't understand. And it's the same for these alleles, the Mendelian randomization on statins. In the epidemiology, having the A or B2 allele is better, but if you're on a statin with long-term follow-up, having the A or B2 allele makes it worse. Having the B1 allele or the C allele is better. So is CETP having a variation on a statin background? And that's the question I pose in this slide, because follow the logic. If you are having a very active LDL receptor, because you've got statins, then a decent way of getting cholesterol back to the liver is to transfer it to HDL, transfer it to LDL, and sweep it back into the liver. That gives you a low-risk situation. If you block CETP and leave the cholesterol in HDL, you're actually denying it access to that potential pathway of reverse cholesterol transport. So when LDL is very low, do you need more, not less CETP? And you can see how this gets quite confusing, because you've got one scenario in the untreated asymptomatic population and quite a different potential biological scenario in individuals who are on maximum statin therapy, where the LDL is down at 0.5 millimoles and receptors are through the roof in terms of protecting. So there's a half-decent story with regard to CETP as a target when you look at the physiology of HDL and LDL and the atherogenic lipoprotein phenotype. The epidemiology is challenging and may depend on the metabolic context in which you actually find that molecule, that CETP, working. So let's look at the inhibitors. Torcetrapib was the parent compound, highly active, greater than 80% CETP inhibition when you gave it to humans. HDL increase was virtually doubled. It had off-target effects on blood pressure that caused problems in trials, but we won't go into that. But here's the CETP molecule itself with a cholesterol ester and triglyceride in a lipid tunnel. So it binds to the lipoprotein, picks up whatever lipid is there, and carries off and drops it in another lipoprotein. Dalcetrapib was developed. The HDL increase on dalcetrapib was about 33%. The amount of CETP inhibition was about 37%. So, gosh, that's roughly equivalent to having the two A alleles as a Mendelian randomization phenomenon, and it should have given you a risk reduction. Anacetrapib blocks CETP about 90–95%, huge increase in HDL, but no off-target effects. So it's been separated from torcetrapib by having these lack of off-target effects. There's another one on the cards from Lilly called evacetrapib, which is very similar in action to anacetrapib. Look at the HDL changes, absolutely fantastic. LDL changes, there's a puzzle going on here. Dalcetrapib had no change in LDL cholesterol, which is strange because remember the model I showed you, LDL, whether you get the genetic mutant or whether you give an inhibitor, HDL cholesterol should go up and LDL cholesterol should go down almost by the same physical amount. The percentage may change because of the difference in baseline, but if you go up by a millimole in HDL, you should go down by a millimole in LDL, because that's how the balance works. Here you go up by about 0.3 millimole, but you don't go down by 0.3 millimoles in LDL cholesterol. But it does happen here. ApoB goes down here, so the number of particles drops as well, as does Lp(a), at least here, and that's another part of the mystery. So these are powerful HDL raising agents, and if somebody asks me, will a 27 or 32% increase in HDL cholesterol associated with CETP inhibition give rise to a risk reduction? The answer should be yes. Other things happen. Part of the dalcetrapib anacetrapib argument over the last 5 years has been what effect is there on HDL in terms of its structure and its function. So not only do we have this story about HDL structure function in epidemiological terms, but we now have it in pharmacodynamic terms as well. And the story developed that dalcetrapib blocked the transfer of HDL cholesterol from cholesterolysis from HDL to VLDL, LDL, but not the remodeling of HDL, which was considered important to generate the small particles that Lena had talked about as being cardioprotective. Whereas torcetrapib and anacetrapib, they said, blocked everything to the extent that pre-beta HDL as a marker of these small, very active HDL particles fell on torcetrapib, anacetrapib, but not on dalcetrapib. And there was lovely arguments about the biology of what this all might mean. What it all means comes really in the acid test of randomized clinical trials. Torcetrapib was tested in imaging studies and in a coronary event trial. And in the coronary event trial, it was a disaster because it increased the risk of disease. And we believe that was off-target effects. But it certainly didn't decrease the risk of disease when you took the whole population of 15,000 patients together. More interestingly, here's an imaging trial on atorvastatin high dose and atorvastatin plus torcetrapib. No change at all in the thickness of the artery wall in the carotid artery over a period of 2 years, when others have shown benefit. If this had been a placebo versus statin, you'd have seen the statin arm showing a reduction in the carotid intermediate thickness compared to placebo. Placebo would have gone up, statin would have stayed the same or gone down. There would have been regression to some extent. So here's an indication that despite the off-target effects, the effect of changing LDL by 15% and HDL by 54% in this trial didn't produce much in the way of a benefit that we could see in that imaging study. Tom Lucia, who's coming, will talk about DAL vessel and DAL plaque. This was part of the DAL heart program that Roche launched. I will summarize that by saying there were indications of benefit, but the most significant fact was there was no significant benefit from these studies. Whether you were looking at plaque composition, the p-value in terms of the amount of disease was not significant, even when you had hundreds of patients. There was a tendency to less, but not significant. And in terms of flow-mediated dilatation, endothelial function, no change. This was interpreted as a de-risking study, but in fact the signal was clear. No change was taking place. Then we had the big DAL outcome study, recruited many thousand individuals, 15,000 individuals, randomized them on statin therapy to placebo plus statin or dalcetrapib plus statin. So they were on optimal therapy, and it was stopped in May of this year for futility. The two lines, the event curves in the two groups, whether you were on statin plus placebo or statin plus dalcetrapib, were absolutely identical in this ACS population. So despite all the workup in the acid test of whether this was a good target or not, we seem not to have got a good result. Is it the wrong hypothesis? Is blocking CETP just shuffling the deck chairs on the Titanic? You're going down anyway. Is it the wrong population? And Kosh will touch on that maybe. Is an ACS population the wrong place to start this HDL intervention? Should we have gone to another population? Was it a bad choice of drug? The drug didn't lower LDL. The drug should have lowered LDL. So what else was going on here? And whether off-target effects, there's been rumours of blood pressure change, there's been rumours of other things. Fundamentally, dalcetrapib was our single best shot at the pure HDL question, because it raised HDL didn't change LDL, didn't change triglyceride, didn't change anything else. 30% rise in HDL, we should have had a good result. People have criticised the niacin trial, the AIM-HIGH trial, which was published last year. But again, they matched people on LDL, and there was a 25% change in HDL. And whether you were on niacin or on placebo or on the background of statin, absolutely no difference between the two curves. So that looks like dalcetrapib plus, that looks like DAL outcomes, AIM-HIGH. Huge amount of criticism with regard to the design and everything else, but at least it's a hit against the story. So now we come on to what we hope will save the sinking ship. We'll jump off the Titanic onto something else, and that is the DEFINE trial with anacetrapib, which is being used firstly in the DEFINE trial to check for toxicity, and then in an outcome trial to check for outcome effects. Here, LDL cholesterol has gone down about 40%, HDL has gone up about 120%. In the DEFINE study in this New England Journal paper, there was a suggestion, and it was borderline significant, that actually the number of coronary events was less on the anacetrapib treated individuals than those on placebo on a background of statin therapy. So there's an inkling that something might be going on here, but remember, this is as big an LDL change as an HDL change. As far as the drug's concerned, that's fine. As far as the hypothesis testing is concerned, it's going to confuse us. So here we have, going forward, the HPS3 REVEAL trial. Huge numbers of patients, 30,000. It's powered to look at LDL change as well as the LDL-HDL change. And we will get the results in 2016. So we'll reconvene at that point in time and figure out what went on. So I'm going to finish with this. There's a decent support for the CETP story as a target for coronary prevention from biology and from genetics. The epidemiology, particularly in statin-treated individuals, is more questionable. And we have to think about the context in which CETP inhibition will take place. Is it beneficial in those on maximum statin effect, in those with a lower LDL level? We've had a couple of strikes against the story with regard to the outcome and vascular studies, and we will have to be patient for the larger trials, HPS3 REVEAL, to give us the answer as far as the CETP inhibitors are concerned, maybe not the answer with regard to LDL versus HDL. Thank you for your attention.